Hi again, this is Cherry. We're going to talk a little bit about musculoskeletal trauma. That's trauma to the muscles and the bones in the body. Trauma is always interesting. I think it is the reason that a lot of us are drawn to EMS. And it's the cool stuff, the blood and the guts and all that good stuff. It truly isn't the most of what we do. Occasionally you get a good trauma call, but most of the time we take care of sick old people. So this will be just an overview of what you know about the skeletal system, and then we'll talk a little bit about some injuries and what you can do for those. So let's talk about the musculoskeletal system and the anatomy part of that first. The very basics I think you know pretty well. We have our bone system. Our bones are a structural framework that give shape to our body. Without those, we'd kind of be like a jellyfish. So they're the hard part. Also in the bones, in the marrow of the bones, is where our red blood cells are formed. So they do play an integral part of the oxygenation system, because if we don't have red blood cells, we can't move the oxygen through our blood. So they are a little bit multifaceted, but for this point, we're going to talk about their function as framework of the body. Part of our bones include joints that join those bones together, some of those bones. And there are different types of joints. There's hinge joints, there's ball and socket joints. Depending on the different type of joints and their functions, they allow us to bend and sort of move. The muscles are what I've lost my word. They're what allow us to move. So the muscles move the bones, and the joints allow that moving so that we can move. Okay. Now going a little bit further, we have the cartilage, and cartilage is a lot like bone, except it isn't. And cartilage is things that you find in your sternum, your breastbone. Part of our ribs are cartilage. Our nose is made out of cartilage, as well as our ears. So cartilage is flexible. It's not as hard as bone, and breaks a little bit easier than bones. Now ligaments are what connect your bone to bone. And I'm not going to spend a lot of time on this because you've already covered a lot of it when you did your anatomy section. And if you have any questions, you can certainly do just a little bit of research and learn this quickly. But ligaments connect bone to bone. That's something that you'll want to remember. And tendons are what connect our muscles to the bone. So ligaments, you have ligaments in your knee, and a lot of times those ligaments are torn when you get, say, a football injury. Somebody hits another player in the side of the knee and hyperextends that knee one direction or the other that it's not intended to go, and you may either stretch or break those ligaments. And when we have ACLs, MCL ligaments in our knees that are frequently injured. And tendons connect muscle to bone. So if our tendons are generally, if they're injured, are stretched or strained, but sometimes they can be torn away. So if that's the case, then it's going to impair our movement. And those do have to go in and be surgically repaired so that we can regain our movement. Okay. So bones are formed of dense tissue. Some of them are very vascular. So some of our bones, specifically our pelvis, has a lot of vessels and arteries running through it. So if we get a pelvic injury, our patient could technically bleed to death in a pretty short time because you've got that femoral artery going down through the pelvis. We need to be thinking about the chance of bleeding. The other thing we can think about is some of our bigger bones, like our femoral, our femur, runs next to our femoral artery. And so if you have some bleed, your femur fractured, it could technically nick your femoral artery. It doesn't happen very often, and it's not common, but if it does, your patient's going to be really, really in trouble. So as you can see from this diagram, we have lots of bones in our body. Okay. From this, you can kind of pick some of those that you probably ought to know. Okay. I really don't care if you know all the bones in your hands and feet and ankles, because there's a ton of them. But some of those main bones, like your humerus, the upper bone in your upper arm, you need to know that. You probably need to know your ulna and radius in your lower arm and figure out which one. We always feel for the radial artery. So that radial bone runs right down by the thumb, because we go by the thumb and then we come inward to check that radial artery. And that's the radial artery sits next to the radius. You need to know things like your femur and your tibia and fibula down here. I always remember the big bone is the tibia because the little one is fibula and just a little fib. So fibula is little. That's how I remember it. You're going to have some silly ways to remember these dumb things, but if it works, it works. The patella is your knee. So that's a good one to remember. On occasion, that patella can be dislocated and slide off of the top of the knee joint where it should sit. It's very painful. It's easy to fix, but it's extremely painful. And it's kind of makes you suck your air in when you see it. We have lots of bones in our skull. We have lots of bones in our face. Two of the most common ones that we need to know are the upper jaw bone, or the upper jaw, which is the maxilla, and that lower jaw is the mandible. You need to know what those are called, because you'll hear those referred to frequently. And your scapula is your shoulder blade. That is the hardest bone in your body to break. So if you've had enough force to fracture your shoulder blade or that scapula bone in your back, we need to start thinking about what kind of damage happened inside the chest, because that's a great amount of force that would fracture that. And very possibly you're going to have some swelling, maybe a punctured lung, maybe fractured ribs, but definitely swelling possibly in the lungs and or heart. So we need to think a little farther than just the fracture that we can see. Your clavicle is your collarbone. It sits up high on the shoulder. And that is the most common broken bone in the body. Okay. Your ribs or your intercostals, your costals, the intercostals are the spaces in between. The costals are the ribs. They're fairly easily broken, especially in our older people, and very, very painful. Another part of that system is your sternum, which is that breastbone that sits right in the middle. Now, when you're doing CPR, you might feel those ribs. And the first part of the ribs you can see here in blue next to the sternum are cartilages as well. And they may break loose from that sternum right there as you're doing CPR. That means nothing more than you're doing effective compressions. Well, you're going to feel that bony crepitus under your hand. Just keep right on pushing because you're doing what you need to do. Okay? And then, we've got the spine, which we're going to talk about here in just a little bit. So many bones are classified by shape. Some are irregular, like your scapula is a little bit of an irregular bone. Your vertebrae are irregular shaped. You have long bones, like your femur, your ulna, your humerus. Those are all long bones. You have short bones, which are more the bones in your fingers, feet, ankles, things like that. Then you have flat bones, which your scapula fits in that as well, as do your ribs. So lots of different shapes. And you can see here some pictures of those and how those kind of all fit together in their shapes. Okay. So when we have a break in one of our bones, it causes our tissues around it to swell. Anytime we have damage, our body's response is to have fluid go there. Excuse me. The theory behind this, I guess not the theory, but the cause behind it, is if we can have fluid go there, it's either going to bring more fluid to the area if it needs it. But in the case of a broken bone, it kind of puts pressure around that bone with the swelling when the fluid builds up in the cells and outside the cells and sort of self-splints that fracture. The swelling will keep the bony fragments from moving back and forth across one another. So although it does prevent or limit some pain, it also causes pain because you have that increased pressure in that area that's already painful. In that process, we oftentimes, if we have a fractured artery or vessel that runs next to or inside the bone, we'll have a blood clot that's going to form at that area to limit the bleeding. So we're going to talk about compartment syndrome when we get a little further into this. So I'm not going to spend a ton of time here because there's more explanation to this. So if we have an interruption of the blood supply, like an artery that is either pinched or cut, then the cells that would normally get their nutrients and oxygen from that artery are going to begin to die. And we're going to leave it at that. They begin to die. So we get some damage from this. Okay. So muscles, cartilage, and ligaments. We have different kinds of muscle, and we'll show you a picture here shortly. We have our skeletal muscles, which are our voluntary muscles. Sometimes you'll hear there's called striated muscles. Okay, oops, I thought I had a picture. There they are. So here's our skeletal muscle, and you can see it's got striations around it. But no, that's a specific kind of muscle that its sole purpose is to move the body. Okay. Then we also have down here at the bottom some types of muscle called smooth muscle, and those muscles are involuntary. So those involuntary muscles are things like your diaphragm, the muscles around your vessels that cause them to either contract or dilate. Also, the muscles in your digestive system that help work your food down through the digestive tract to be processed and eliminated. Okay? So those are all involuntary muscles. And then the third kind is a cardiac muscle. And as you've learned about the cardiac emergencies, we know those are very specific types of muscles in the fact that they can create their own electricity, they can conduct electricity without them being damaged, and they can develop what we call automaticity. They can develop their own rhythm, and those are the cardiac muscle is the prima donna muscle of the body. It's very sensitive to oxygen and nutrients. It squawks really loudly when it doesn't get what it needs, and it dies quicker than other muscles in our body when it doesn't get the oxygen or the nutrients. Okay, so the cardiac muscles obviously are found only in the heart. So we've got our voluntary, our involuntary, and then our myocardial or our cardiac cells. So our cartilage helps forms flexible structures of the body, and we talked about that, our nose, our ears, breastbone, some of those different types of things. Okay, so we talked about tendons allow for movement across the joint. And you can remember MTB, muscle, tendon, bone, is how those are connected. And then BLB is the other one, bone, ligament, bone. That kind of tells you how the ligaments are put together. So ligaments support the joints, and they attach the bone ends together so that we've got a range of motion, but it also limits how far we can move our muscles. Okay, so here's another little diagram on how those go together. You can see here on the right-hand side, you've got your ligaments tying the bone together. And then over here on the left, you've got the muscle and it's moving into the tendon, which is attaches to the bone. Okay. So let's talk about how we're going to care for these people. First of all, we need to think about our mechanism of injury because it's going to play a big part in the type of injuries our patients are going to have. So when we talk about mechanism of injury, we're talking about how much force and what type of force. So we can have a direct force, which is a direct blow to the body, okay? Or we can have an indirect force that if you're in a motor vehicle and you're driving, and let's say your car hits a tree, okay? The direct force is the car hitting the tree, okay? There's another direct force because the car hits the tree and the car stops, okay? That is a direct force. Then our body hits our car. So whether it's a seatbelt, airbag, windshield, whatever we hit, that is another direct force. The indirect force then is our organs are still moving long after our body has stopped. And then we get that force of our organs hitting the inside of our body. Other types of forces that we see regularly would be twisting or a rotational force. We see that a lot on young kids, parents grabbing their arm and twisting, or twisting as they pull, or flipping them around, and we get that twisting fractures. We call them spiral fractures in those long bones. So a fracture is any break in a bone. And we categorize those by saying they're open or closed. Open obviously being that it's an open wound. The bone has penetrated through the skin, and we actually have access into the inside of the body through that wound. Okay. Well, a lot of times, most of the time, you're going to have closed fractures where you have the fracture of the bone, but it has not penetrated through the skin and remains closed, which definitely reduces the chance of infection. Commuted fractures are bones that are broken in several places. Now, we talked about in the airway section, flail segment, or where we've got two or more ribs broken in two or more places, and that part of the rib that part of the chest appears to be moving in an opposite direction as the rest of the chest wall. So those type of fractures would be a commuted fracture. Other things you may see is somebody that's got more of a crushing injury. Sometimes you see lower leg bones broken in two or three places. Same thing with femurs, depending on the type of injury and the force involved. Okay, green streak fractures are types of fractures that the fracture is there, but it's not displaced. So you can see it. We call them, sometimes they're called incomplete fractures. So the bone is fractured. You can see the crack in the bone on an x-ray. They're a little bit harder to see, but the bone is still in place. Okay. And then angulated fractures are where the bone is actually bent at an angle. So you're going to see that very obviously in your extremity where that bone is actually bent. Okay, so here's just a picture of a closed fracture. It's not really a good trauma lecture unless you've got a couple gross pictures in here, right? Okay, so here's our closed fracture, and you can see right down here, this bone should be inside the leg here, and it's fractured and pushed its way out here. So interesting to see. Sometimes these are very painful and sometimes not as much as you would expect. Our big concern here is going to be the circulation past that. Okay, and I think that's what this provider is doing, is checking pulses there to make sure we have circulation in that foot. Okay. So other types of injuries we can have are dislocations, and that literally means the coming apart of a joint. Frequently you see shoulder dislocation, finger dislocations, and sometimes hips, where nothing's fractured. It's just that the joint has been pulled apart or has come apart, and it needs to be put back together before we can move. They are very painful, and these are very easy to see that they're dislocated when that happens. There's definitely a deformity noted. Okay. Now, sprains and strains for us in the field are going to be very difficult to assess because we need to rule out the possibility of a fracture. So we're going to treat more sprains and strains just like we would a fracture, because we're not going to be able to really for sure identify what we have going without more interventions like x-rays. So a sprain is when we stretch or tear those ligaments. Okay? And like I say, those happen a lot in the ankles. Okay, and sometimes with football and sports injuries, we find those same things in our knees. Okay, a strain, on the other hand, is overstretching or overexertion of the muscle. So that's the muscle itself gets torn a little bit. Those are painful. Sprains are extremely painful, and they're all going to swell. So it is very difficult for us to diagnose in the field what exactly we are dealing with. Good thing is the treatment for all of them are exactly the same. We're going to immobilize them. We're going to check and make sure that they have pulses past the point of injury, and we're going to bring them in for x-rays. Okay. So we're going to splint an extremity with a suspected fracture, and knowing it may be a strain or a sprain. And that's going to do two things. It's going to reduce the pain. When we quit moving it around, it quits hurting. And it's going to prevent any blood loss. So if our patient is bleeding internally because there was some compromise to the circulatory system with this fracture, it's going to help minimize that bleeding. If we quit moving it around, the body can probably clot the blood at the site and the bleeding will stop. So we want to rapidly identify any life-threatening conditions with these patients. It is really, really easy to get caught up in the very obvious dramatic stuff. So if you've got a broken femur, if you've got bleeding, massive bleeding, or a big deformity, it's very easy. We call those distracting injuries because most of the time they're not life-threatening. However, they sometimes cause us to miss something that is life-threatening, like maybe difficulty breathing, or maybe lung sounds that are absent on one side because we get so wrapped up in treating this femur fracture that we don't even listen to lung sounds. Okay, so we cannot deviate from our ABCs. We have to do that primary assessment. And we have to do the secondary if we have time before we get caught up in the gross stuff. So with these patients, we are going to want to cut their clothing off to look at things. And you're going to have patients who are like, oh my gosh, these jeans cost me $130. Well, if I can't access your injury, I have to look. So the jeans are going to get cut off. Little hint, if you cut up the side seam of your clothes, then you can lay the clothing back over your patient and number one, keep them warm, which is really important with your trauma patients, and B, provide them with a little modesty. If we cut up the top middle part, you can't really fold that back over because it doesn't stay. So I always try and cut down the side seams. It just works better. Told you we were going to talk about compartment syndrome. So what compartment syndrome is severe swelling of an extremity as a result of a fracture. So let's say that we fractured our tib-fib in our lower leg. We fractured both of them just below the knee. Well, because of that fracture, our body is going to try and do what it can to repair that. And so it's going to swell. Okay, those cells, and there's a long process involved there, but water is going to come out of the vascular system and out of the other tissues, and it's going to gather in those cells around the fracture. It's going to be in the cells, around the cells, and so we're going to get increased pressure at that site. If our increased pressure becomes so great that it starts to pinch off the vessels that are going through there. So let's say we get so much swelling that our arteries become compressed and we can't move blood through the artery to get oxygen and nutrients to our lower leg and foot, then our patient runs the risk of losing that limb. So we have to recognize compartment syndrome, and that's why we always check for CSM, circulation, motor, and sensory. Some people call it PMS, whichever works for you is fine. But we have to check for that circulation, motor function, and sensation, because we can also pinch off the nerves with that increased swelling. So that's why we always check before and after we splint, and then continue to check as we move along, so that if there is compartment syndrome that's going to happen there, we can take some measures to reduce that. We aren't going to, but the physician will. But it would be to our patient's advantage if we recognize it and let them know. Okay. So what we're looking for when we do an assessment on a patient that has a possible fracture or musculoskeletal injury, we're looking for pain and tenderness. And we're going to find that when we do that secondary assessment, or what the patient tells you when you get your sample history. So when you're doing this, you need to touch and feel every part of your patient's body. Now, you need to have a little bit of finesse when you do this, but simply running your fingers down the outside of the leg is not palpating that leg. So I want you to take your whole hands and palpate and feel and push and do a little twisting and see if you can find anything that's abnormal. Okay. We're looking for deformities and angulations, so you're looking at things that look a little deformed. A lot of times what you see is simply kind of a bump, maybe a little swollen area. And ask the patient if it hurts. If it's swollen, I don't just reach in and start grabbing and palpating it, because there's a really good chance it's going to hurt. So if they can tell you that they hurt there, that's all you need to know. You really don't need to palpate that area. Sometimes I have my patient touch it and tell me if it hurts when they push. That way they know when it hurts and when to stop pushing, whereas I wouldn't. We're also looking for grading. We call it bony crepitus, and sometimes we call it just crepitus, but it's those bone ends grading against each other. And you find those a lot with ribs. Sometimes with fractures, you'll see them, especially if we have compound fractures or comminuted fractures where we have multiple fractures going on. We're looking for swelling and bruising because, like we said, there's going to be vessels there, and you're going to have a little bit of bleeding, at least a little bit of bleeding with each fractures, maybe sometimes a lot. We're looking for exposed bone ends, either under the skin or those that have protruded through. If they have protruded through, we want to take every precaution that we can to keep that clean. Okay, because now we run the risk of getting debris and bacteria into the bone, and that can cause some very serious issues. We want to check our CSM. We're looking for blood and nerve compromise, and then we want to be looking for compartment syndrome. So in this process, we're going to look at the 6 Ps. Okay, the thing we're looking for is pain, pallor. That pallor is pale skin. I mean, we could have just used P for pale, but, we had to make it fancy. So we're looking for pale skin, which is going to indicate that we're not getting the circulation that we need, or if our entire patient is pale, that they're in shock. Okay. We're looking for paresthesia, and paresthesia is that pins and needle feeling. If you've ever had, say, your hand go to sleep, and when it starts to get circulation back and wake up, it gets all tingly. My little sister used to call it sparkles in her fingers. Okay, that feeling tells us that we have some neurological compromise, that we have some nerves that are compressed and damaged. We're looking for pulses. We want to check and make sure we don't have anything that's diminished or absent. We're looking for paralysis. I think that's pretty self-explanatory. And we're looking for pressure, would be that swelling, okay, that causes increased pressure. Okay, so in our patient care, obviously BSI, we want to do that primary assessment, and I cannot stress to you enough how important it is to do the primary assessment. If their leg is laying there all bent, 3 ways to Sunday, it's not going to get worse. But if they're not breathing well, that could get worse. So check your ABCs. Get the important stuff first. Our limbs are very, very rarely have life-threatening injuries to them. So take care of the important stuff. And then during our secondary assessment, we want to deal with some of those musculoskeletal things, like putting on a C-collar. Okay? Don't ever put your C-collar on until you have your ABCs done. Okay? So we want to do manual C-spine, and then once we've assured that we don't have any life threats, we're going to go ahead with that C-collar, measure it, and apply it, and get it on our patient. Now, a C-collar doesn't mean that our patients can't move. We still have to hold manual C-spine. Okay? So then we're going to splint any suspected extremity fractures after we treat our life-threatening conditions. And if we have any open wounds, we want to make sure that we cover those with a sterile dressing or as clean of a dressing as we can find. Okay, it's not that we always carry sterile with us, but something that's very nice and clean, like a 4x4 gauze that's packaged so it's clean. Pull it open and get it on there as soon as you can so we don't get a lot of debris in. Okay. Now, I think most of you have or will very soon be working on your skills in the lab. So splinting is something that we're going to practice there, but here's why we do it. Again, it minimizes the movement of the bones. It prevents any additional injury to the nerves, the muscles, the veins and arteries that might be in close proximity to that fracture. Sometimes when we get a fracture to the bone, it has kind of a splintering effect, and we have long, sharp edges that can cause a lot of damage. When we don't move that around like that and cause the damage, it obviously decreases our pain. So number one for the patient is going to be to decrease the pain. For us, we want to prevent any additional injury, and we want to minimize any blood loss. Okay. Also, by fracturing or by splinting a fracture, apparently I can't talk very well tonight, but by splinting that fracture, we reduce the risk of a closed fracture becoming an open fracture. If we move it enough, we stand the chance of poking that bone in through the skin, and that we don't want to go there. Okay, so it's sometimes, rarely, but sometimes you're going to have a fracture and you don't have circulation in your extremities. So let's say we have an arm fracture and we can't find a radial pulse. Then we want to think about doing a realignment. If you've got good circulation, we aren't going to mess with this. Okay, we're going to leave it like it is if we can. Okay, but if you're lacking circulation, then we want to think about realigning this to reduce the pain and possible further injury and restore circulation if we can. Okay, now you need to adhere to your protocols on this. In general, we allow EMTs one try, and paramedics as well, one try to realign the extremity. And if you can't get it, then we're going to splint it and transport. Okay, you can see how this EMT has got her partner there. They're keeping the extremity. So let's say the fracture is probably going to be right in here. So this female EMT is going to pull in line, straight in line, and try and get the bone realigned in more of a normal position to hopefully restore the circulation. Okay. So some people are going to tell you if it's horribly, disfigured, that it's going to be hard to splint. And that's true. It can be. We do have a splint called a vacuum splint, which a lot of departments use nowadays. And the vacuum splint, the beauty of that is it can conform to any deformity. And they are awesome. They support very, very well. They are painless for a patient to put on. The problem is they're kind of expensive to buy. So if you don't have that and you have to realign in order to splint, know that you have that one chance. Pull in line and try and reduce that as much as you can. Okay. The increased pain that causes will only be momentary, and hopefully the pain relief will be something that's going to help them long term. Okay. So we talked about this. If no resistance felt, maintain genuine traction until the extremity is properly aligned and splinted. Okay. So ingenuity is required with splinting. I'm not going to spend a ton of time on this because you guys are going to be practicing it in the lab. But rigid splints are basically something hard. Could be a magazine. We have some cardboard splints. We have some padded board splints that we use. Old school, there's some metal, they call them ladder splints. They're metal framework that are bendable. Lots of different things we could use for rigid splints. We have formable splints, and that's where our vacuum splints are going to come in. That's also where we might use a pillow as a splint. Pillows truly make awesome splints, and they mold to just about anything. And then we have our traction splints, which are for our midshaft femur injuries. Okay, so here's a lot of the things that we can use. Here's a Sager splint. That's a traction splint. Here's our padded board splints. Here's some air splints. Here's a blanket roll that we could use. This is a vacuum splint. You see it's got the pump right here. So it's kind of like a really soft beanbag splint. And you just put it around and then you suck the air out of it and it gets really tight and hard. And then this hair traction splint right here. Now there are videos on your course page showing how to use most of these. I will try and find one with a vacuum splint and put on there as well. But the rest of those are all on your course page, so take a look. Okay, so again, before we splint, we've got to make sure we do that primary assessment and look for life-threatening problems. We kind of want to reassess for those if you have a serious mechanism of injury, because chest injuries can get worse with time. And so if you have a pneumothorax that develops as you're taking care of your splinting, you would want to recognize that as quickly as you can. So expose our injury site, check our CSM, make sure that you know what you're dealing with, okay? If you don't have circulation, motor movement, or sensation, then we need to move a little faster and see if we can get that reduced down so that we can restore some of that, okay? Any long bone injuries, we're going to see if we have any what do I say here, disorder, any circulation or sensory motor disorder. We want to align that if we can. One thing we got to keep in place is we're not going to push the protruding bones back into place, okay? If they're sticking outside of the skin, we want to leave them outside the skin so we can clean them up before they go back in. So immobilize both the injury site and the adjacent joints. Or if we're doing a joint, then we want to immobilize the bones above and below that joint. Okay, so find our splint that we want to use based on what we're dealing with. There's different splints are going to make different, or be better for different situations. You know, it doesn't have to be some commercially manufactured thing. If you've got a little pillow there and you can use that pillow and wrap around and secure that and stable it, that works perfect. Okay, so apply the splint before and after, before moving the patient to the stretcher, if possible. If you find anything in your primary assessment that has you concerned, you can manually mobilize that and move your patient to the stretcher, and you can splint en route. In fact, I would highly recommend that you do that. And then once you get them on the stretcher, whatever, or on the long spine board, we want to pad any voids that are there to make them more comfortable and limit the chance of movement. Okay. There's an old saying that you can splint your patient to death. And that's very true. I think I've said it 3 times thus far. I'm going to say it again. We cannot splint before any life-threatening conditions are addressed. So we've got to do our ABCs. That being said, then we want to make sure that our splint is correct and that it's not too tight. Okay? We don't want it to cause more swelling. And if you've ever put a rubber band on your finger and seen what happens, your finger swells. It turns all kinds of weird colors. I wouldn't know exactly how I know that. I'm not going to tell you anyway, but the splint will do the same thing. If it's too tight, it's going to cause more damage. If it's too loose, it's not going to do its job. It's going to be moving around over the top of that fracture and cause more pain. So it needs to be tight enough to be secure, but not so tight that you're cutting off circulation. Okay. So take BSI, expose your area, manually stabilize your injured site. Now, you don't have to do this. If your patient is capable of manually immobilizing that limb or extremity, by all means, let them. It gives them something to do. They know when it hurts and when it doesn't, so they're the perfect one to do some immobilizing. Oftentimes when you get there, your patients already have it immobilized. So all you have to do is check a pulse, see if they can wiggle their extremities, and move on to splinting. Okay. So there we are, immobilizing the situation. Now, she's got her hands completely full. If her patient was immobilizing this, it would free her up to do some more work. So if she's going to immobilize, so she's going to have her partner come in and help her splint that. Okay. Again, assess our CSM, realign our deformity if we need it. If it's cyanotic or pulseless, then we want to make sure that we do some realignment. Okay. So checking for CSM, measure or adjust our splint, put it into position, apply it, and then reassess our CSM afterwards. Okay, then we want to secure the splint. Now, I always make sure that I secure that so that I can still check pulses. Okay, I still want to be able to look at the fingers. I still want to be able to check a radial pulse and make sure that things are fine. So, sometimes I'll just put a couple little wraps around that so I can see a good share of the arm, but it's still secure. Okay, and then reassess. Okay. Our traction splints counteract muscle spasms and reduce pain in our mid-shaft femur fractures. So in your skills videos, you're going to see there's 2 different types. There's a bipolar traction splint that we call a Sager splint. Sager is the brand name. Okay. I'm sorry, a bipolar is a hair traction splint. Bipolar has 2 poles, one on each side of the leg, and it is designed for the splinting of one leg. Okay. Then we have our unipolar, which is our Sager splint. It's 1 pole, and it is designed to immobilize one or both femurs. Okay. So what we want to apply is roughly 10% of the patient's body weight in pounds per square inch. Okay. So we don't want to go over 15 pounds. So depending on our patient's weight, obviously little kids are going to be, or younger kids, smaller people are going to be less than that, but we know it's going to be 10% of the body weight, not more than 15 pounds. Okay, so BSI, manually stabilize the leg. Again, check CSM. We're going to adjust the strap. We're going to put on the ischial strap so that the splint will stay in place when we apply traction. We're going to apply the securing ankle hitch around the ankle and then apply mechanical traction. Please know what type of splint your department has before you have to use it. So drag it out, play with it, look at it. If you need to Google the use of it or the instructions, please do. There are several different manufacturers out there, and they are used very differently, so make sure that you know what you have. Okay, again, reevaluate our CSM before we're done. And then we're going to put our patient on a long spine board to immobilize the hip, because remember, we're immobilizing the joint above and below the fracture, so we need to immobilize the knee. Your traction splint will do that, but we also have to immobilize that hip so that it isn't moving and pulling those muscles further. Okay, so shoulder girdle injuries. You're going to notice this with pain in the shoulder. Oftentimes our patients are going to present with what they call a drop shoulder. One shoulder is much lower than the other. And if our patient has suffered a severe blow to the back over the top of the scapula, as we talked before, that's pretty severe, and it can cause those shoulder injuries as well as other injuries. So again, we're going to check our CSM. We're going to use a sling and swath, because what we want to do is immobilize that shoulder. So if it looks like we have an anterior, which is to the front side of the body, dislocation of the head of the humerus. So the humerus is the bone that's in the upper arm and goes up into the shoulder. If that is dislocated, it's a good idea to put a pillow between the patient's arm and chest so that you can hold that shoulder, that humerus up. If you try and bring it down in close to the chest, you're going to cause a great amount of pain and maybe compromise some circulation. So if it's up and out, then put a pillow in there to leave that in the position that you found it. Okay? Don't attempt to straighten it. Reducing is a term that we use when we put a dislocated joint back in place. That is not something that we're going to do in the field. Okay, so we're going to transport them generally in the position of comfort or the position they're found. And then we're going to check CSM after we get them bundled up and make sure we haven't caused any further injury. Pelvic injuries can be noticed with pain in the pelvis, hips, groin, or back, lower back. We're going to notice it when we're doing our secondary. We're going to put a little bit of pressure on the iliac crest, right on their pelvic bone. Put a little pressure downward, and then we're going to reach our hands around and try and pull those iliac crests together. At either time, they should not move. But if they do, then we're going to suspect a pelvic fracture. And again, as we talked, pelvis bleeds a lot. So a pelvic fracture is something that would be of great concern. Okay. Other indications might be that the patients can't lift their legs when they're lying on their back. For the reason is that it puts pressure on that pelvic bone and hurts, so they don't. You may find a lateral rotation, which means the foot is pointed to the outside of the body. So lateral rotation of the foot, and you see that a lot with hip injuries. Frequently with pelvis injuries too. So the one foot, as they're laying on their back in a supine position, one foot may be straight up. The other one would be rotated out and pointing more outward. Okay. If your patient tells you that they have a great amount of pressure in their bladder, or if you notice that they're bleeding from their rectum, in their urine, which I don't know how we would always know that for sure, or their vaginal opening, we want to think about that they've got some pelvic injuries. Okay, so these guys, we want to move them very, very carefully. If you've got a scoop stretcher, this is a great tool to use for them, because you can slide that under them without moving them much. So we want to, again, check our CSM on our distal, so on our feet, and straighten our limbs to an anatomical position, stabilize our lower limbs, and we're going to assume that they have spinal injuries as well. Okay. So once we get them moved, we want to, again, check for CSM. So these patients can be moved very gently. So straighten out the legs if we need to. I like to use the scoop stretcher because there's not a lot of rolling or pressure. We're not moving them a lot. We simply slide that scoop stretcher under them, move them over to the cot or to a long spine board, whichever you decide would be most advantageous. If we're assuming spinal injury, then probably a long spine board would be appropriate. We're going to recheck for CSM and then watch for shock. And it's not going to hurt our patients to be treated for shock. So in other words, we're going to keep them warm and we're going to give them some oxygen if they need it. Okay? And we're going to transport them as soon as possible. It's going to be very important to trend the vital signs on these patients because there's a great chance they could be bleeding inside. The only way you're going to know that is by watching the vital signs, and that would be the pulse rate and breathing rate will go up, and the blood pressure may stay the same for a while and may start to decline. So we want to watch those very, very carefully. In the retroperitoneal area, which is kind of the backside of that pelvic area, there's a space back there that your entire blood content can bleed into there, and you really wouldn't see a lot of outward signs. So your only indication of that is going to be watching your vital signs to know that. Okay, so there are some commercially available devices to use for pelvic injuries. And here's one of those. It's a wraparound. There's several different ones. But you can see here that this wraps around, not up at the waist, this wraps around their hips. So it's going to be around their hips and their butt. And it's going to pull together. There's a certain amount of pressure that these will apply, and I believe it's 17 pounds of pressure, I think. But as you pull them in, they'll apply the right amount of pressure, and it just eliminates pain, but it also eliminates the chance of us moving that too much. It helps us move them without causing more damage. So the problem with these is you have to get it under your patient. So if you're going to move your patient to a long spine board, I would lay this on the long spine board and then move your patient to the top, on top of it. Here is our lady who's been injured, and we're going to use a sheet to do the same thing with her. So we lay a sheet, we fold it flat, and it's about 10 inches wide. We lay it across the backboard. Okay. Then we're going to move her onto that backboard and bring our ends of the sheet together. You can almost see the deformity in her hip right there. And then we're going to tie it nice and tight. I think I might move this one up just a smidgen on her if it was a pelvic injury. Okay. All right. So looking at hip locations. I know we're going through this quickly, but I know you have your book to look it up in. So anterior hip location is when that femur, that ball of the femur, pops out towards the front of the patient or towards their front side. And a posterior is when it pops out kind of more towards the back side. So you're going to see in a posterior an inward rotation of the leg, and the knee will usually be bent. Okay. Sometimes that foot hangs loose, and they cannot bring it up or lift their toes. Okay, and oftentimes you're going to have lack of sensation to the limb because it does pinch off the nerve pathway to that limb. So you're looking for rotation. You're also looking for shortening. Sometimes it will shorten the leg. Okay. But this is very painful, very much, probably more so than a broken hip. Okay, so we're going to check our CSM, put them on a long spine board, immobilize them with pillows, blankets, whatever we can to keep that. We don't want them bouncing down the road on this long spine board, moving this dislocation all over. So this is going to require a little bit of TLC with your patient, and padding with some pillows and blankets, maybe putting a blanket on the board so you've got something under them to build on, and then secure them. This is going to be a gentle transport because it's going to hurt. Okay, so reassess our CSM, watch for shock, and again, monitor those vital signs because we don't know if they're bleeding inside or not. Okay, now, gentle or direct force and twisting forces can cause hip fractures in our geriatric patients. Okay, so motor vehicle collisions or simple ground level falls frequently fractures hips in our older population. So watch for that. There's also quite a number of hip fractures that happen, the hip fractures, and then they fall. So sometimes it's like, there really isn't any indication of why their hip got fractured. And it just may be that there's a weakened spot there, and as they took a step and maybe stepped on a pebble or rotated their foot a little bit on uneven ground, and it snapped that femoral head off and caused it to break. So we have to be careful with those little ladies. And I had one patient that got up and walked. She had a hip fracture, and she got up and walked across the room to a chair. So when we got to her, she was sitting in the senior citizen hall in a chair and thought she could probably get up and walk. And we convinced her maybe not to try anymore and got her. It was hard to tell with her. She did stand up and, assured us that she could walk to the cot. But when we stood her up, I could see her foot was rotated outward when she stood. So we carried her and laid her down. And once she was laid down, I could definitely see that her leg was shortened and rotated. And that shortening is a dead giveaway sign of a hip fracture. So it was interesting, though, because she didn't have a lot of pain, and she was pretty sure she could walk, and she actually did, even with that fractured hip. So they're tough old goats sometimes. Okay, usually our pain is localized with a hip fracture. If you look, you will have some dislocation, maybe some swelling. Usually you can see the deformity. Okay, and usually they're unable to stand, almost always. But their foot or injured is going to turn outward, whereas the dislocation, their foot is going to turn inward. And we're going to see that shortened. One limb will be shorter than the other. So the injured side is going to appear to be shorter than the non-injured side. So we're going to place a folded blanket between our patient's legs and bind our legs together with maybe a sheet or some straps, anything to kind of keep them together, because we're using the good leg to splint the bad leg. Okay. So we're going to try and secure those just above the crotch, below the knee, and then again at the ankle, so we keep those all in line. Okay. Our femur shaft fracture, this is probably one of the more awesome fractures. Oftentimes a lot of pain, possibly open fractures, but if not, you almost always will see what looks like a little swelling or a bump. And if you run your hand gently down that, you'll notice the deformity there. And like with the hip fractures, this limb might be shortened when we have that femur fracture. Now, the muscles around the femur and that upper thigh are very, very strong. Strongest muscles in our body. They are strong enough when they tense up to actually, when they contract, to pull those bone fragments side by side and shorten up that entire leg. If that happens, our patient's going to have to go into traction for quite some time, even to maybe 2 or 3 days, to lengthen out those muscles so that we can put those bones back together in an aligned position. So the reason for that traction splint is to eliminate that contracting and shortening of that leg. Okay. Other things that they're going to do is reduce pain. So for us, we want to control any bleeding that they have. After we do the ABCs, we're going to manage for shock. We're going to provide oxygen. We're going to look for CSM, put our traction splint on, and then check for CSM again to make sure we haven't done any harm. Okay. If you have a child with a femoral fracture, you're only allowed to put a traction splint on if you have a pediatric traction splint. Okay, so it has to fit your patient. Now, if you've got a teenager or an older one that will fit in an adult splint, that's fine. I don't know of too many agencies, if any agencies around, that have a pediatric traction splint. So if you don't have it, then we're just going to splint it like a long bone splint and get cooking. Okay. Keep in mind though, because children have soft, flexible bones for the most part, if they had enough force to fracture their femurs, we very well may be looking at internal injuries too. So the femur fracture might be the least of our worries. So keep reassessing your primary assessment and make sure that our patient isn't declining when we're not looking. Okay. Again, we talked about the patella, that kneecap sliding off. Lots of injuries can happen: tendons, ligament injuries, dislocated patellas, but all of them are going to show up with pain and tenderness. They're all going to have some swelling and usually have some sort of deformity, at least with swelling. With all the rest of our things, CSM is important. We're going to immobilize it in the position that it's found, because knees hurt, and moving them around, we could certainly cause a lot more damage. So this may mean putting pillows under your behind your knee, the patient's knee, so that we can transport them without moving that knee around. This may require a couple, 2 or 3 people to help hold that knee while you move them onto your cot. Tib fib, we're going to treat those the same as we would any long bone injury. We can do those using vacuum splints, air splints, long bone splints, rigid splints of some kind. If we're going to do a rigid splint, we want to put one on either side of the injury if you're going to do that, to make sure that it's very secure. And check for CSM before and after. When you have ankle or foot injuries, and we see a lot of these, hiking, camping, running, football, soccer, jumping off of stuff, everything causes ankle injuries. So they're going to be noted mostly with a lot of pain, some swelling, maybe some deformity. A great way to handle those is to stabilize it and put it on a pillow. So the cravats are the triangle bandages. So I put those under my pillow, lay my foot right in the pillow, kind of fold it up gently around my foot and ankle, and then use my triangle bandages to tie that all on and secure it. If you do it right, you can secure the lower leg and the foot and immobilize that whole thing as one chunk and not cause any further injury, because you have a nice soft pillow. It's very comfortable for the patient and very effective. Okay, so here's this. If you want to put one across the bottom, and you can kind of make sure that you've secured that foot so it can't move up and down also. Okay, we just talked about that. Put an ice pack on any swelling. If you've got an ice pack or one of those chemical packs, and you do have some swelling on your extremity, it's nice to place those on top, making sure that you've got a little something in between so we don't cause any skin damage with the cold. Okay. Again, our wrists, hands, forearms, there's a couple things with those that are a little different than others. Forearm is simply a long bone injury, so we're going to splint that, making sure that we check CSM before and after and immobilize the joint above and below. With the wrist, SAM splints work great for those, or pillows, either one. And then hands are a little different. If we've got fingers that are broken, we generally, if we have one finger, you've got a finger on at least one side of it that isn't. So we can tape the injured finger to the uninjured finger, and we've got a nice splint right there. Sometimes we can use a tongue depressor. If you happen to have one, you can see this gentleman's got a tongue depressor on the bottom side of his finger there to keep it nice and straight. Now we could also secure that to his other finger if we wanted to. Okay. We don't want to try and pop a dislocated finger back into place. We can compromise circulation and all kinds of things with that. So we're going to leave that up to a physician to do. So they'll x-ray it, then they'll reduce it down. Any dislocations this way, they'll reduce it, but they give the patient some muscle relaxant and a little bit of sedative because it's very painful. And they put that back in place, and then they x-ray it to make sure that it is in the right place.